Sensitivity and specificity. So these, don't freak out, everyone's like, oh my god, my notes. This is a separate file in the notes. It's like epidemiology 101 or something. I stuck it in because I realized you guys don't have epidemiology. So really quick, this is a super complicated topic. Don't freak out about it. We're just gonna introduce it and we'll come back to it. And you will probably ask lots of questions on the discussion board. That's a good place for this. Sensitivity and specificity. These are qualities inherent to every diagnostic test. Diagnostic tests include things like histopathology, bacterial culture, PCR, fecal flow. All those are diagnostics. A TPR is technically a diagnostic. So every test you run has these two qualities inherent to the test itself. You need to understand the difference between these two things because that's going to help you choose which test is the most appropriate for your situation. This is all the same information about 10 different ways. So depending on which way you digest it. If you like numbers and math, this chart is for you. It's not for me. I don't understand. I don't think this way. I think in words. So the sensitivity, if you test a bunch of animals with this, whatever the test is, every test has these two numbers. Choose a test a bunch of animals. The sensitivity of that test is the true positives divided by all the animals that have the disease, which is the true positives and the false negatives. If that makes sense. Okay. So basically this is the percentage of animals with actual disease that test positive. So this is also known as the detection rate. I'm using this for screening things. I don't want to miss any negative results. I don't want false negatives. So with a sensitive test, I can trust a negative result. Does that make sense? SPIN and SNOUT are the acronyms I'm gonna give you for this. SNOUT, SN is sensitivity. So a sensitive test, when it's negative, and is negative, rules out the disease. We use tests that are highly sensitive to rule things out because we can trust negative. Does that still make sense? Okay. If you're into statistics, things with higher sensitivity that will give you a lower type 2 error rate. So a type 2 error is like letting a criminal go free. It's a false negative, right? So with a high sensitivity, we can trust that everyone that we equip is innocent. That's negative test. Okay. What is this? Oh no. Specificity is the flip. Okay. So it's true negatives divided by everyone who doesn't have the disease. So the true negatives plus the false positive are everyone without disease, right? Does that still make sense? It makes sense now when you're gonna leave this room and you're gonna be like, I don't understand any of what just happened. So the specificity is the percentage of healthy animals that are testing negative. Okay. So this is used for confirmatory tests for diagnostics. SPIN, a specific test when it's positive rules in the disease. Sensitive test that's negative rules out the disease. A specific test that's positive rules in the disease. So this is a higher specificity is a lower type 1 error rate, which would be convicting an innocent person. That'd be a false positive, right? This reduces our false positives. We can trust positive. SPIN for limited.
Would like a parvo snap test be like a specific test like this?
All tests have both values. These are numbers that go from 0 to 100%. So you can all go home and Google, you have your computers, you can Google it right now. What is the sensitivity and specificity of a parvo snap test? And it'll give you two numbers, probably somewhere between 80 and 90%. So I think that's a decent test. I know parvo, so the snap test with parvo, this is a great example, actually. Let me think about it for a second to make sure I don't say the wrong thing. So a parvo snap test has both sensitivity and specificity issues. a SNAP test is detecting antigen in feces. A lot of times on the floor, we get animals that have been tested for parvo by a SNAP test, and we always test them again if we think it's parvo. Because we run different tests that have a higher sensitivity and are more likely to be positive. Does that make sense? So, not super great on sensitivity. It's probably a decently high number. It's probably above 80%. Most commercial tests are pretty high. But we cannot trust a negative SNAP test that it's definitely not parvo. So it is not super sensitive, it's not 100% sensitive. Specificity of the parvo SNAP test. Canine parvovirus and feline parvovirus are cross-reactive. So it's unlikely that a dog would be infected with feline panleukopenia virus, but this SNAP test would not tell us the difference. So it's also not a super specific test. If it comes up positive, it could be canine parvo, it could be feline parvo, or it could be some other species parvo, right? Because they all cross-react. So it's also not an extremely specific test. Does that make sense as an example? It has sensitivity problems because a negative result does not always mean they don't have disease, and it has specificity problems because a positive result doesn't always mean that they have disease. The classic example I use, you really want a sensitive test for screening things. So for example, TB tests in cattle. I do not want to miss a single positive, right? Because that's a dangerous reportable disease that can be transmitted to humans and kill us, it's zoonotic. So I want a really sensitive test. I want to know that if a cow tests negative for TB, it does not have TB for sure. That's sensitivity. Contrast that when I now have a cat who the owner suspects, or you as the vet suspect it has FIP. The prognosis for that is not great. Getting better with new drugs, but still currently not great. If you're testing this animal for FIP and the owner is going to euthanize if it's positive, boy, you want a specific test. You want to know that that positive is 100%. This is FIP. It's not cross-reacting with some other disease because I'm going to have to kill this animal, right? So a negative test, less consequential for this animal than a false positive test. A false positive would be really, really bad. False negative, you miss FIP, the cat dies anyway. Happens, right? False positive is what you really, really don't want. You don't want to euthanize a cat that does not have FIP. Where's mud?
Yeah.
Any questions? They'll come, yeah.
What's like a trustable number?
A trustable number.
Yeah, but you said it's about 80, maybe.
There's no way I can answer that question. It depends on what you need from the test. So that's why I'm teaching you these numbers, that you can, every test you run, you can go up and look, these numbers are published for every commercially available test. You can look, and you can say, do I as a doctor need a test right now that's really sensitive or really specific? If your test is both great, you don't have to think about it. If you have one that's only 60% sensitive but 90% specific, that's a great test for certain scenarios. It's not going to be a great test for other scenarios. Depends on what you're using it for.
We're talking about like SNAP tests.
All tests, every test
Okay, so if we're doing like a PCR, you know, we do a blood, it's the same,
has a sensitivity and specificity.
probably gonna be higher than the SNAP test.
Well, that's a great question.
I'll Google that.
PCR is highly sensitive, but it suffers from a lot of false positives because it's also too sensitive. Yeah, right?
Yeah.
Other questions? I'm teaching you this because it's something you have to think about in the future. Ugh. Yeah, that's my age. All right, so the reason I had to teach you that is because we're learning these words and I have to mention sensitivity and specificity and how they apply to these words. So now we're back to fun stuff. Put all that out of your mind. Pathognomonic. A gnomon, it's not a gnome, it actually means an indicator. So an indicator of pathos, something that is pathognomonic, it's an adjective, that is a lesion that is so specific that I can see it and be like, oh yeah, that is this disease 100%, because those two things, that lesion and this disease go together like shoot, Okay, so if I see it, I'm like slam dunk, bang, that disease. So pathognomonic lesions have a high positive predictive value. They're very specific to the disease. They are not sensitive. You don't always see them with these diseases, but when you do see them, you can be like, oh, that is a screaming positive and I can trust it. That makes sense. Context of everything we just said. So pathognomonic lesions are really important. They are pretty uncommon, but we get really excited when we see them because it's an easy diagnosis, right? You see it, you're like, oh yeah, that's it, he's done. It's kind of like when you smell parvo. You're like, that's parvo, I've smelled that before, right? It's specific to that disease. An example, my personal favorite, case-eating granulomas in the lung of a human being, pathognomonic for tuberculosis. You see that? That person has to be run and hide. Hide them, don't hide you.
Are pathognomonic things, things you observe, like an objective finding on an exam, or can they also be something you test for? Like, you test a tumor, or like, oh, it's this kind of tumor.
Yeah, definitely. So there are, we're gonna talk a little bit, I think it's point about biomarkers, disease in the blood. Some of those biomarkers, if they're elevated, that's pathognomonic for a certain disease.
There's
Yeah.
any kind of like.
It's anything that's so classic that it's a 1-1 correlation between the thing and the disease, it's pathognomonic. This is one of my favorite examples, this is tetanus. This face that the dog has is called rhesus sardonicus, or the sardonic grin. See how it looks like he's smiling? All of his facial muscles are tense. So his mouth is pulled open, he's grimacing. His eyes are really tense and tight, his ears are pulled back. And this is pathognomonic for tetanus intoxication, this facial grimace. Rhesus sardonicus. So spin and snout, it is very specific. If you see it, that's tetanus. But if you don't see it, I can't rule out tetanus. The dog might still have tetanus, they don't always look like this, but if the dog looks like this, it has tetanus, take it to the bank. Like Dr. Eden told me, this is tetanus for sure, I don't even have to test. They'll be like, is she a pathologist, and she only work with dead things? If you listen to her in clinics. Okay, any questions? Or some words. It's all downhill from here, I promise. All right, diagnosis. This is the description and recognition of different aspects of the disease. There are different types of diagnoses. They are given by different specialists or practitioners, and they describe different aspects of the disease process. So this dog is your example patient. It comes to you in the clinic, you would probably diagnose it clinically with forelimb lameness because that's the clinical sign it's exhibiting. It doesn't tell us anything about the etiology or the pathogenesis or the cause, I think it's etiology, but it gives you a diagnosis, tells you what's wrong with the dog. A pathologic diagnosis, what we're going to do in here is, you know, I would take this dog to imaging, or it's me, so I would probably take it to autopsy for this, and I would diagnose a fracture of the radius. I would characterize it as, you know, complete, comminuted, whatever. I'm looking for an etiologic diagnosis. What caused this dog to be lame? He was hit by a car. That's my diagnosis of the cause. And then probably most importantly for you guys in this class and the next 4 years is going to be this concept of differential diagnoses. So you have your diagnosis, and then your list of differential diagnoses are diseases that could look similar or be confused with that diagnosis. So for example, we think this dog was hit by a car, maybe we don't have that in the history, maybe it's a stray, we don't know what happened. So we want to look for these other diseases and rule them out to make sure that our diagnosis was correct. So maybe this dog has metabolic bone disease, maybe he's a stray, hasn't had the best diet, bones are soft, maybe he has an infection, maybe he's got a tumor there. So these are all differential diagnoses for this presentation. That makes sense? Differential diagnoses, so again, these are other similar diseases that you have to consider as diagnostic alternatives. I had a professor that says if you can only think of one differential diagnosis for a lesion or a case, you're not thinking hard enough. This is an exercise in I should stretch myself and try to find other differentials, as many things as I can think of that could look like this, because that's how we eliminate bias, right? Bias is when you latch onto a thing, you see something, you're like, oh, I think it's this disease, I'm pretty sure it's parvo, I don't need to test for anything else. What if it's not parvo, what if it has salmonella, right, that's gotta be on your differential list. In school, we're teaching you the blue box, so we're focusing on the middle of the bell curve. In real life, there's lots of stuff out here, so the middle of the bell curve is gonna be the classic, most classic presentation. Real life things aren't really as classic, so that's where your differentials come into play. If you guys have a disease that's right here on the bell curve, coming up with 20 other differentials is not gonna be super important. It's when you're down here in the weeds and the weirdo presentations that you're gonna be like, you're so far from the classic that you're like, I don't know what this is. This has to still be on the list as a differential, but I also have to have a bunch of other things. So here's an example of a disease that is very broad on the spectrum. It's like a lot of different things. This is a kidney from a cow. I would consider this top center image to be the most classic presentation of renal lymphoma in a cow. But here's the spectrum. It can cause nodular masses, but it can also cause diffuse infiltration. So much that we're not even sure this is a tumor. This is just a diffusely pale and large discolored kidney, right? It could be swollen from infection. This could be amyloid. This could be a lot of things. It could be hydronephrosis. I have no idea. I would not jump straight to lymphoma necessarily by looking at this. And then there's this. This is a bunch of tiny little dots. Could this be embolic nephritis? Could these be little bacterial colonies coming through the blood and seeding? Yeah, definitely. Those could for sure be inflammatory. I'm not even 100% sure that's cancer in this image either. So every disease is going to have this kind of bell curve or spectrum. And for your differentials, there are a lot of diseases that don't have a lot of overlap. So the ability to distinguish between them on a pathologic basis is very good. They don't look like each other. For example, lymphoma in a cat kidney and polycystic disease in a cat kidney. Here's your cysts right here. These are epithelial line spaces. They're dilated, they're fluid filled on the surface. Before we cut through them, they'd probably be fluctuant. But here we've cut into them and all the fluid has come out and you just have these big dilated spaces. This is lymphoma, so you've got infiltration of tumor cells throughout the cortex, kind of focused on the corticomedullary junction. Super easy to tell these apart, no one is getting these diseases confused. Compare that to renal lymphoma in a cat and FIP in a cat. If these weren't labeled, could you tell me which one was which? I couldn't even tell you which one was which. These diseases look so similar. Really hard to tell apart, we need microscopy for this. So this is the case where your differentials are going to be important. If you see this kidney and you say, oh yeah, that's lymphoma, and you settle on that confirmation bias, I would do that. Could be lots of other things, could be infectious, could be FIP, especially, could be systemic fungal disease. So these are the cases where your differentialists are going to be way more important. All right, a couple more words to top it off. Enopathy. So this is an ending you could put on an organ, so it would be like a hepatopathy or a nephropathy. This is like the least specific way to say that there's something wrong with the organ. There's something wrong and I have no idea what it is. It has an organopathy, a hepatopathy. Dog liver that had the big tumor and then the weird texture, I would call that hepatopathy. I know there's something wrong with the liver, it's not quite right, but I have no idea what that is, because that change is very non-specific. Not specific for anything. Osis is different from apathy. Osis means we have a specific disease or a specific pathologic condition. Some of these are infectious, some of these are not. We had a cirrhotic liver, so cirrhosis, coccidiosis, hydronephrosis. Itis tells you there's inflammation. So itis is specific to inflammatory processes. Again, it's organ itis, so hepatitis, nephritis, brainitis, in the second year class sheet. Encephalitis, brainitis. Oma is a swelling. We often use this to describe tumors, so adenoma carcinoma, but it can also mean other non-neoplastic things, so like a seroma or a hematoma is a non-neoplastic swelling, right? All right, and then I think last thing, morphologic diagnoses. You guys aren't gonna have to do this until fourth year, I think, I might do a tiny bit second year, it's mainly in fourth year. This is how I communicate my bottom line diagnosis to a client, so I'm gonna give them a duration, how long has this been going on? How severe is it, in my opinion, that's subjective. What is the distribution? Is it focal, multifocal, diffuse, or some other version? And then the main word of this morphologic diagnosis is going to be the process. Those process words are gonna be interpretations, and they're gonna follow pretty closely with these modules in GenPath. So is it inflammation? Is it a tumor? Is it cell death or degeneration? It's circulatory disturbance, that's your process, so that tells you what actual thing is happening. These other words just quantify it, how bad is it, where is it, how long is it going on? Process is the big thing. Here's some examples, put those on your own. I think it's, oh, I got one. Prognosis. So this is an informed prediction of the likely outcome of disease. It's based on past experience, it's based on literature, all this data that has accumulated. What I, as a pathologist, do is I will grade a tumor for you. Send me a tumor, I will predict how it's gonna behave based on how cells look. How mitotically active is it? How crazy do the cells look? How different do they look from their normal cell origin? How much necrosis is there? How much death is going on? A stage is something that's done by the clinicians. This is done by the oncologist. And this is predicting tumor behavior based on the clinical features. So tumor node metastasis, TNN is the acronym. What is the tumor? How big is it? Where is it? Node, is there a lymph node involvement? Has it spread? And metastasis, has it spread throughout the body? So that's a stage. Here's an example of how, sometimes how we show that prognostic data is through these survival curves. All right, last thing, what's the cause of disease? The etiology. How does disease develop? What's the process from start to finish? Pathogenesis, what does it look like? What are we seeing with our eyes? You're giving me a description of a lesion. What are the effects of the lesion? Who wrote this? Oh, the clinical signs. Obviously, what do we call it? This is a D word. Diagnosis, but what else could it be? It could be your differential diagnoses, and what predictions are we gonna make? Prognosis. Any question? Write these out.
Well, you have spring break.
No. You're funny. Oh. Yeah, I will send out now that please be patient, stay tuned.
At least you're letting go with you.
That would
Yeah.
No,
Bruce?
The background was.
fine.
Here you go.
No.
Yeah. Yeah, after shopping every year, October. You can't go to German school.
That's
All right, thanks all. See you tomorrow.